Hi there, let's get started with this warm-up review. First question, which organism produces an exotoxin that works via each of the following mechanisms? First, it activates EF2, which is elongation factor. So this one is Corynebacterium diphtheriae, also Pseudomonas exotoxin A. Next, activates GS. So this one is Vibrio cholerae, and also ETEC heat labile toxin, which is enterotoxigenic E. coli heat labile toxin. Next, disables GI. This is pertussis toxin. Next, bacterial adenylate cyclase. This is Bacillus anthracis. And blocks GABA and glycine. This one is Clostridium tetani, which causes lockjaw. Next question. What drug is used to help make the diagnosis of myasthenia gravis? So the drug is edrophonium. The brand name of the drug is Tensilon, and we call it a Tensilon test. The drug is too short-acting to be used to treat myasthenia, but we definitely use it to make the diagnosis. Next question. Which heart sound is associated with dilated congestive heart failure? So think about the dilated ventricle. It's the S3 heart sound. And which heart sound is associated with chronic hypertension and a stiffened left ventricle? So that would be an S4 heart sound. Okay, that's it for this warm-up review. Let's move on to the lecture.
We've just been talking about B cells and antibodies. And in this video, we're going to talk about two issues that are related to antibodies: immunization and autoantibodies. In the previous video, we briefly mentioned that passive immunity is where you give somebody preformed antibodies that were made outside their body to enhance the immune system for a short period of time. And obviously, this is going to provide immediate immunity. An example of this would be the IgA found in breast milk. The IgA in breast milk provides a certain amount of passive immunity against specific pathogens. But these antibodies have a short half-life, around 21 days. Now that doesn't mean that all the antibodies are going to be gone in 3 weeks. It just means that half of them are going to be gone in 3 weeks. So for the most part, if you're going to give immunoglobulins to provide passive immunity over an extended period of time, you have to dose those around once a month. So for example, take RSV, or respiratory syncytial virus. RSV is a virus that can cause a very severe respiratory infection in young children, especially neonates, and especially premature neonates. So in premature neonates that were born in the winter months when RSV is around, you can give them an antibody against RSV that's called palivizumab. You give that once a month if they meet these specific criteria. And these antibodies are going to bind the RSV virus and protect the baby from getting infected. And that's passive immunity. Another example is rabies. If you get bitten by a rabid dog or skunk or whatever, you can go get a series of shots of rabies immunoglobulin so that you don't get infected. Now, active immunity, on the other hand, actually involves exposure to foreign antigens, either because the patient had a previous infection or maybe they were vaccinated against something. Now, you know how vaccines work. You give a killed virus or an inactivated virus or a bacterial antigen like a polysaccharide from a capsule or something. You inject that so that the patient's immune system can activate some B cells and T cells against that antigen and be ready in case they ever come in contact with the actual living pathogen. And instead of providing immediate immunity, active immunity takes a few weeks to develop. So with that first exposure, in addition to ramping up the production of T cells to fight the infection and ramping up B cells and plasma cells to produce IgM and eventually IgG, antibodies against that pathogen, you're also generating memory T cells and memory B cells, which can stick around for long periods of time and provide that active immunity. So most of the immunizations that we routinely give, like tetanus, influenza shots, MMR, pneumococcal vaccines, all those are examples of active immunization. Now, if you have that patient who's exposed to rabies, we give both the rabies immunoglobulin for passive immunity and we give the rabies vaccine for active immunity. And if someone comes in with a wound that's high risk for tetanus, we sometimes give both the tetanus immunoglobulin for that passive immunity and the tetanus vaccine at the same time. Let's talk about vaccines in a little more detail. We're going to start with the vaccines against viruses. Now, as I mentioned, there are different types of vaccines. You have live virus vaccines and inactivated or killed virus vaccines. So with a live virus vaccine, you're actually giving the patient the infection, but it's a very weak, attenuated form of the infection. You're allowing that weakened virus to infect cells so that those cells can present the viral antigens to the cytotoxic T cells. So live vaccines lead to cellular immunity. those cytotoxic T cells will not only kill off those infected cells, but some of those activated T cells will go on to become memory cytotoxic T cells, which go dormant and wait around for the virus to show up next time. And that's what provides that long-term, maybe even lifelong immunity. Now, a student wrote in with a mnemonic to help us remember some examples of live attenuated virus vaccines. The mnemonic is, attention, please vaccinate young infants with MMR regularly. So attention is to remember that this is a mnemonic for live attenuated virus vaccines. Then the P in please is for the Sabin polio vaccine, which is the oral polio vaccine. The V is for varicella, which is chickenpox. The Y is for yellow fever. The I in infants is for the intranasal influenza virus. So you can remember infant intranasal influenza. And then MMR is for MMR, measles, mumps, and rubella. And then the R in regularly is for rotavirus. So that's a pretty good mnemonic. Now, one other thing I want to mention about live viruses is because you're actually giving a live virus, generally you don't give live viruses to immunocompromised patients. Or if you have a patient that's around immunocompromised individuals, you might not want to give the live virus vaccine to those patients either, because you don't want them to expose the immunocompromised patients that they're around. But there are a couple of exceptions to this rule. MMR and the varicella vaccine and the yellow fever vaccine can be given to HIV patients as long as that HIV patient has a CD4 count above 200. So the way you can think about it is just because this patient has HIV doesn't actually mean that they're immunocompromised yet. So if the CD4 count is above 200, you go ahead and give those vaccines because the benefits outweigh the risks. Measles, for instance, causes about a 40% mortality rate in HIV patients. So as long as the CD4 count is above 200, go ahead and give those live vaccines. Now, those are the live virus vaccines. Now we're going to talk about the inactivated or killed virus vaccines. Now, here the virus isn't able to infect the host cells, so there's actually no cell-mediated immunity generated. You're just putting antigen into the patient so that that antigen can be recognized by antibodies on the surface of B cells, and that's eventually going to produce antibodies against the virus. So that's humoral immunity, right? Now, these non-infectious vaccines can also induce the production of some memory helper T cells. But one issue with these inactivated virus vaccines is that in some cases this immunity can wear off over time, so booster doses may be needed. So the killed or inactivated virus vaccines include the intramuscular influenza vaccine, not the intranasal, the hepatitis A vaccine, the rabies vaccine, and the Salk polio vaccine. So that's not the oral polio vaccine, that's the injected polio vaccine, the Salk polio vaccine. You also need to know which vaccines are egg-based vaccines. So influenza vaccine and yellow fever vaccine both use viruses that are grown inside of eggs. So if you have a patient with an egg allergy, those patients need to be skin tested before you give one of these egg-based vaccines. Now, the MMR vaccine is also egg-based, but it's such a tiny, tiny amount of egg that you don't have to really worry about it. So those are viral vaccines. Now, bacterial vaccines tend to be either vaccines against the bacterial toxins, like tetanus toxoid, or vaccines against polysaccharides on the capsule of things like strep pneumo or H. flu. Or sometimes we actually give killed bacteria like Vibrio cholera. Or you can give live attenuated bacteria like in the typhoid vaccine or in the BCG vaccine against tuberculosis. But in all these cases, because these bacteria aren't actually infecting individual cells, there won't be a cellular cytotoxic T cell response. So again, bacterial vaccines generally are going to induce a humoral B cell response. Now, one other thing to consider with bacterial vaccines that use toxins or capsular antigens is whether or not those antigens have a peptide component. So peptide antigens or protein antigens are called thymus-dependent antigens. Thymus-dependent antigens are antigens that can be presented on the major histocompatibility complex. So MHC molecules present peptides, and that means that the thymus can present that antigen to T cells during T cell selection. This means that when we're exposed to that pathogen, we have helper T cells that are able to mount an immune response and generate IL-4 and IL-5 and activate some B cells, and that's going to promote antibody class switching from the IgM antibodies to more abundant IgG antibodies. So those peptide antigens, those thymus-dependent antigens, induce a better immune response and a better immunologic memory. Then thymus-independent antigens are non-peptide antigens. which means they cannot be presented to T cells in the thymus. That means there's not going to be a T cell response. That means that the B cell response is going to be weaker because, again, helper T cells are important for activating B cells. So with these thymus-independent antigens, the immunological memory is weaker and boosters are more commonly needed. So one good example of an antigen that cannot be presented to T cells is lipopolysaccharide, which is the endotoxin found in gram-negative bacteria. Sometimes when we design a vaccine against encapsulated bacteria, we don't just give the lipopolysaccharide component. We actually conjugate that lipopolysaccharide to a peptide, and that allows it to induce a more lasting immune response. Now let's talk about autoantibodies, which is where your immune system turns to the dark side and starts making antibodies against your own normal antigens in your own tissues. Let's look at number 4 in your study guide, where there's a huge table listing autoantibodies that are very high yield for step 1. Now, this is at least a 4-star topic. So as we go through each of these, I want you to write down the disease associated with the antibody. Now, we've already seen a bunch of these autoantibodies in rheumatology, and we're going to see some of these others later on. And I've kind of grouped them by organ system, which may help you kind of keep them straight in your mind. So let's start with some of these autoantibodies we've already seen elsewhere. The first one is antibodies against IgG, or anti-IgG antibodies. This is also called rheumatoid factor, which is associated with rheumatoid arthritis. The next one is anti-citrullinated protein antibody, or ACPA, which is a little more specific for rheumatoid arthritis. ANA, or anti-nuclear antibody, is the classic autoantibody for lupus. But remember, this is fairly nonspecific for lupus. And then anti-Smith antibodies are also seen in lupus, and they're much more specific for lupus. And anti-double-stranded DNA antibodies are especially associated with lupus renal disease. And then anti-histone antibodies should make you think of drug-induced lupus. About 50% of patients with systemic lupus will be positive for anti-histone antibodies, but 90% of patients with drug-induced lupus will be positive. And remember that the mnemonic for the drugs that typically cause drug-induced lupus is SHIP, S-H-I-P-P. You can go back to rheumatology if you need to revisit that. Then anti-centromere antibodies are seen in crest scleroderma, so C for centromere, C for crest scleroderma. And then anti-SCL70 is pretty easy because that SCL stands for scleroderma. This is diffuse scleroderma. The other name for this is anti-DNA topoisomerase. Anti-Jo1 is seen with polymyositis and dermatomyositis. Anti-SSA and anti-SSB, remember SS is for Sjogren's syndrome, so SSA is also called anti-Ro, and anti-SSB antibodies are also called anti-LA. And there's an antibody called anti-U1RNP, or ribonucleoprotein, which is seen in mixed connective tissue disease. The next one is from dermatology, which is anti-desmoglein, which is seen in pemphigus vulgaris. Now, if you have anti-acetylcholine receptor antibodies, what disease is that? That's myasthenia gravis. Next, we have a couple of GI diseases. So the anti-endomysial or anti-tissue transglutaminase antibodies and also the anti-gliadin antibodies are both seen with celiac disease, where you have a gluten intolerance. And that leads to blunting of the microvilli on your enterocytes, and it leads to malabsorption. Then anti-mitochondrial antibodies are seen in primary biliary cirrhosis, and anti-smooth muscle antibodies are seen in autoimmune hepatitis. In the endocrine system, anti-glutamate decarboxylase antibodies are sometimes seen with type 1 diabetes. Anti-thyrotropin receptor antibodies are seen in Graves' disease. So these are the antibodies that bind to the TSH receptor and stimulate the thyroid gland to start releasing too much thyroid hormone in Graves' disease. Anti-thyroid peroxidase or anti-TPO antibodies are seen primarily in Hashimoto thyroiditis. And there are also anti-thyroglobulin antibodies that are seen in Hashimoto thyroiditis or in Graves' disease. So there's actually a lot of overlap in the thyroid autoantibodies. And then a few autoantibodies we see in certain kidney diseases. Anti-basement membrane antibodies are seen with Goodpasture syndrome. Remember, Goodpasture syndrome can affect the kidneys and the lungs. And C-ANCA is seen with granulomatosis with polyangiitis, or the older name for that was Wegener's granulomatosis. And this can also affect both the kidneys and the lungs. So I want you to link those two together in your mind. If you see kidney disease plus lung disease, think about either Goodpasture syndrome or granulomatosis with polyangiitis. And then P-ANCA antibodies are seen with a type of glomerulonephritis called pauci-immune crescentic glomerulonephritis. They're also seen with Churg-Strauss syndrome and a type of vasculitis called microscopic polyangiitis. Let's finish up by talking briefly about amyloidosis, which is basically where you have accumulation of too much of one specific type of protein in the tissues. Now, that could be accumulation of immunoglobulin, which is why we're talking about it here, or it could be another type of protein. As that excess protein is deposited in tissue, it starts to form beta-pleated sheets, and the tissue starts getting thicker and thicker and bulkier. And all that bulk can actually interfere with the normal function of the tissue. So if you had cardiac amyloidosis, that might cause thickening of the heart muscle and lead to CHF, or it might interrupt the conduction system and cause some arrhythmias. Or if you had renal amyloidosis, that might cause nephrotic syndrome and renal failure. Or you can see deposition of amyloid in the walls of blood vessels, and that can lead to strokes and heart attacks. So there are lots of different clinical presentations for amyloidosis. Let's look at some of the different types of proteins that could cause amyloidosis. Now, this isn't very high yield, but it is fair game. There's immunologic amyloidosis, such as in multiple myeloma, which is where you have proliferation of plasma cells that are just making way too much immunoglobulin. And it's specifically the antibody light chains that cause the problems, and they coalesce to form AL proteins. So AL is for amyloid light chains. This is also called primary amyloidosis. Then secondary amyloidosis occurs when you have chronic inflammation, and that leads to accumulation of an excessive amount of an acute phase reactant known as serum amyloid-associated protein. So you have a chronic inflammatory disease like rheumatoid arthritis, and that causes too much of this serum amyloid-associated protein. That can form these AA protein molecules that can then form amyloid. You can also have excess amylin. Amylin is a minor hormone that's secreted by the pancreas along with insulin. And in cases of type 2 diabetes, where there's insulin resistance and the pancreas is working overtime to make extra insulin, the pancreas is also going to be making extra amylin. And that's going to form an AI-APP protein that's going to cause amyloidosis. Now, if you have medullary carcinoma of the thyroid, where there's too much calcitonin produced, that excess calcitonin can form ACAL protein, which can cause amyloidosis. In Alzheimer's disease, there's something called amyloid precursor protein, or APP, that's cleaved to beta amyloid, or A-beta, and that builds up in the brain. So in a way, Alzheimer's disease is amyloidosis of the brain. It's not diffuse multi-organ amyloid, it's just discrete plaques of this A-beta protein in the brain. And there's dialysis-associated amyloidosis, which is where a protein called beta-2 microglobulin builds up. So be aware of these different amyloidoses. Not incredibly high yield, but fair game and possibly worth knowing. But one thing that's definitely worth knowing is how to diagnose amyloidosis based on a biopsy. You need to know that you use a Congo red stain, and that's going to cause the amyloid protein to light up bright green under polarized light. And you might see that described as apple green birefringence with a Congo red stain. Make sure you know that. All right, now we're ready to go ahead and work through the end of session quiz, and then we'll go over those answers together. All right, first question. Which viral vaccines are potentially dangerous to patients with an egg allergy? So we mentioned influenza vaccine and yellow fever vaccine. Remember we said MMR is also egg-based, but it's a small amount of eggs, so you don't really have to worry about it. Next question. What autoimmune disease is associated with anti-double-stranded DNA antibodies? That was lupus, systemic lupus erythematosus. Last question. What stain is used to identify amyloid microscopically, and how is its appearance described? So the stain is the Congo red stain, and then amyloid protein shows up as apple green birefringence under polarized light. All right, that's it for the quiz. I'll see you next time.